Okay, hello Pierre. So happy
Hi.
to have you. Pierre Saintigny is professor in oncology. In the clinics you do care about patients with head and neck cancer mostly.
And lung cancer, yeah.
And lung cancer. And in the research, Pierre is specialized in early stage of cancer. So that's the topic of our podcast today.
Okay.
And also personalized medicine and molecular medicine. So Pierre, my first question for you today is, could you describe to us the general steps of the development of cancer, please?
Okay, thank you, Loïc, for inviting me. So you can view this as in different ways. One way is clinical. So the clinical perspective, I just focus in the area that I'm most expert in, is the oral cavity. Some patients develop some white patches. The most frequent one is oral leukoplakia, and some of those may or may not develop. You can also view this at the histological level. We know that patients, when we do biopsy those lesions, may have hyperplasia, which is an increased number of cells, or dysplasia of various grades, and sometimes, we can see a in situ carcinoma. But of course, one of the most interesting features that we need is our molecular features. We know that there is an accumulation of epigenetic alterations. We also know that some of them result in phenotypic changes that we can capture. We call them phenotypic changes. We can capture them using transcriptomic approaches. Finally, there is a large body of evidence now showing that there is a lot of changes in the immune contexture. This is, of course, heavily studied in invasive, established tumors, but very clearly those changes also happen very early during this tumorigenesis.
Okay, very interesting. So I think we'll go deeper in all the features that you described. But first, there is a stage of cancer that is very early, which is called, I think, if you confirm, pre-cancer. So could you give us kind of a definition of what is pre-cancer? And then we'll go in depth.
So this is sort of a subject of debate to define pre-neoplasia or dysplasia or pre-cancer. There has been a lot of different terms describing those stages, very early stages. I think one of the way I like to present those very early steps is the term lesion, meaning clinically visible lesion, or histologically abnormal pre-cancer lesion that has the potential to develop cancer, to transform to cancer. And this notion of potential is very critical because this process is reversible. So it opens the avenues toward the development of interventions that may actually reverse the process. Or more and more people use the term intercept the process of transformation.
That's very, very interesting, of course, because we were not used to this reversibility, at least in the advanced stage of or metastatic stage of cancer. So my question is, what are the molecular knowledge of those early steps, and how could you explain biologically that they are reversible?
I think it's complicated to answer to provide a definitive answer to this question. You have to view these lesions with potential to develop malignancy as an unstable stage. We need to understand at this point of time where the lesion may develop to cancer or may actually be reversed to the normal stage, which are the molecular mechanisms that we can leverage. So clearly we have shown, for example, in some preclinical models that the immune checkpoint PD-1, PD-L1 in the oral cavity may be actually actionable at this stage. And there are 2 clinical trials ongoing, one in the US, one in Italy, that are actually testing the value in high-risk populations with oral pre-malignancy, the value of giving this immunotherapy. This might not be the optimal strategy on the long term, but these are very important proof of concept studies.
Okay, very interesting. So are there other molecular descriptors that are important either to define pre-cancer or even to develop some actions or some targets?
So I would say that the description, the study of the landscape, the genetic, epigenetic, transcriptomic, immune contextual landscape of those pre-cancer stages, are ongoing, and we still clearly have not a very good idea of what's going on longitudinally. We need studies to do so, so that hopefully those studies will allow 2 things. One is to identify predictors, because in the vast majority of those patients, at least in the oral cavity, for example, but this might be very true in the lung, this might be very true in many other tissues, those lesions will not develop to cancer.
Yeah.
And so we need to identify those patients with a high risk, not to increase anxiety, not to increase this kind of situations in which it's useless to have to engage in a specific treatment. But at the same time, to identify those patients at high risk that at least can benefit from now on of very specific clinical care in terms of screening, and hopefully at some point we may be able to propose them to enter clinical trials testing interception strategies.
Yeah, it's critical, and there are 2 examples that come in mind about those clonal phenomena that you can see in the clinic in routine. For example, when you do circulating DNA sequencing from patients with metastasis, it's very, very frequent that you see clonal hematopoiesis from alterations that are specific. So, and that's indeed the main question for me, and I think currently is where you put the threshold to go for investigation or not. Another example is for esophageal mucosis, where it has been shown, and you can maybe describe it to us because you know it well, some clones or clones of cells with molecular alteration quite specific to cancers, but that won't go into this cancer stage.
Yeah, so you're asking a question relating to this whole field of the genetic alterations found in normal tissues.
Yes.
And this has been studied in different settings, but as you were saying, the one that has been the most extensively studied in the UK especially, and the group of Michael Stratton, is the esophagus. And he has shown that if by studying biopsies from patients with absolutely normal esophageal mucosa, he was able to describe multiple clones corresponding to mutations of different genes And it's interesting to see that at a similar age, some individuals may have more of those clones, abnormal clones, but those clones increase as the patient is getting older. But there is no clear association for now, and because we don't have the data, between the rate of these clonal clones appearing over time. We don't know if the number of clones is important. We don't know whether this is just an effect of age. And so this is a whole field of study that we need to do, and for which we need to have prospective follow-up.
Okay. In order to build up those studies, there is a great deal about putting up networks, and you're participating in the interceptor networks. Could you describe it to us? What is this initiative?
So this is a European-funded effort by COST. So the idea is to intercept oral cancer by the study of oral potentially malignant disorders. So this is an effort that is very multicentric. Many countries are participating, right now 25 European countries. We have different working groups for clinical challenges, pathological challenges, biological challenges, and the idea is to have a network that will be able to build together some proposals to be submitted to EU calls. For example, one of the things we are doing now is that we are lacking large cohorts, well-defined clinically, even retrospective ones, sort of a registry, if you will. And so this is one of the deliverables of this. Okay. And the idea then, of course, would be to get the samples, gather the samples, and describe them with multiple data layers, and with the goal to identify, to improve risk assessment of oral cancer.
Okay. So given your experience in the field of oral cancer and all the research you did and you're doing on the molecular characteristic of precancer, could you share with us some of your bets for the future? What could be the most important targets, molecular, immune or epigenetic, and how we could improve the early detection and curability of early stage cancer?
Okay, so that's a big question. I think that the best strategy may not be the use of immune checkpoint modulators. These have been associated with potential side effects, and in this setting, we cannot afford, severe toxicities that are not so frequent, but may happen. So I think vaccine strategies might be of interest, and this is a very large field. And actually, we have one example with an organ that is, in a way, an epithelium that is very close to the oral cavity, which is the cervix, and in which a very strong antigen has been identified in the, as the HPV. Unfortunately, HPV is not associated with oral cancer, but with oropharyngeal cancer. So we cannot really use this strategy for oral cancer. But if we can find a way to leverage the immune response, I think we may be able to reverse the process and avoid transformation to oral cancer.
Okay, very nice. So thanks a lot, Pierre, for all these insights.
Thank you.
And see you soon on this topic that is very active.
Okay.